everyone to this 108th session of Mero Eye Talks webinar. Today with us we have a very special guest, Dr. Thomas Aller, and he will be talking on topic the use of multifocal contact lenses for myopia control. Before he begins, I would like to give his general introduction. Dr. Thomas is an OD Fellow of British Contact Lens Association and a visiting scholar in School of Optometry in University of California, Berkeley. He is also an editor of myopia.org. He is even a scientific and clinical advisor at Treehouse Eyes in California. I welcome you, Dr. Thomas, on the behalf of Mero Eye Foundation and all our participants. Over to you, Dr.
Fine, yes. Thanks for the invitation to speak. I ended up traveling to Nepal, as you can see, so that I could speak in your country, or at least I wish I could. Maybe one day we'll be able to get there in person. So I will be speaking about the use of multifocal contact lenses for myopia control. That is a project that I've been on for just about 30 years, which is an extremely long time. And it's taken a long time for the profession and industry to agree that there are ways to slow myopia. And we'll go through some of the evidence and why it should become the standard of care, this and other treatments. All right, let's see. All right, those are my disclosures. I do have a number of patents in the area of myopia control shared with Brian Holden Vision Institute these days. And I receive honoraria, consulting fees, etc., travel expenses from these various companies. So keep that in mind. And then relevant to the US, but probably relevant to Nepal as well. Virtually all of the treatments and lenses I'll be discussing are considered off-label in the US. Of course, the FDA has no jurisdiction over actually how we practice, and certainly has nothing to do with how you guys practice in Nepal. So you might be more regulated than we are, you might be less regulated. But mostly these approvals govern how companies can talk about their products, not so much how doctors can use their products. Now, for the last several years, or maybe annually, the Contact Lens Spectrum does surveys of their readers, and lately they've been focusing on myopia control. And there have been an increasingly higher percentage of practitioners. That's mostly a US population, but just readers of the spectrum, where 42% of their readers say that they actively practice myopia control in 2019. And that was a 50% increase from 2018. And I expect that's going to go higher and higher. Most doctors think that, the contact lenses are the most effective. That includes bifocal contacts, orthokeratology, and many of them like to add atropine as an enhancement. And I understand you folks can use atropine in Nepal, so that's a great way to boost the effectiveness if you're finding that you're not getting the treatment effect that you want. Says here 10% prefer atropine alone, and that mostly they use 0.01%, although if their next survey, I suspect that percentage, not the percentage of users, but the preferred percentage of atropine should increase from 0.01 to a little bit higher dose. And their editor in 2018 made the statement that given the prevalence of myopia and the consequences of high myopia, that failing to offer these forms of treatments to patients would be borderline unethical. And it's certainly going to approach the standard of care. Now in these slides, either now or later, oftentimes I'll have a QR code and you can just scan that to get those articles if you'd like to read them. And they usually have a contact lens event of the year, contact lens spectrum. And for the last 2 years, myopia control has been the event of the year. So it's definitely a growing trend, and it's gratifying for me anyway, after 30 years, to see that it's gaining some traction. You may have seen slides like this. It doesn't include Nepal. I couldn't find any data, but presumably it's close to the prevalence of India. There's some difference in prevalence and even in the Asian countries between rural and urban. So you have the highest percentages in urban East Asia and still not as high in the rural areas. So there's a little bit of a mix there, but you can see the percentages are quite high, and they're getting higher and higher. This is showing the predicted trend in the world. So about 2 billion myopes in the world now, projected to increase to about 5 billion by the year 2050, with 1 billion of those having high myopia. That's from the Brian Holden Vision Institute paper. Now, if myopia were only a matter of thicker glasses that gave good vision, it wouldn't have really any significant consequence. But as we know, there are significant risk factors to high myopia. And the obvious ones relate to pathology that seems to be related to the stretching of the eye. And so retinal detachments, retinal tears, a newly described condition, although it's been around for a long time, myopic maculopathy or myopic macular degeneration, where the macula gets scarred and you get profound vision loss, is being tracked now separately. So we'll get better data on that in the future. But less well appreciated is that there are increases also in the risks of cataract formation and also glaucoma. And you can imagine glaucoma. I'm not quite sure about cataracts. What's the rationale? I think there might have been a recent paper on it. But with glaucoma, there's a stretching of the globe, or with high myopia. And so you get maybe thinner tissues and might be more subject to damage from glaucoma. And this is just showing the consequences of myopic maculopathy. You can see in that photo there, down there, that's an eye that's really going to have profound vision loss. And this particular condition, as shown on this slide, is the #1 cause of new blindness in Shanghai, for example, and in other areas as well. And this is just showing the estimates of how many people in the world by that same 2050 might have visual impairment or blindness related to myopic maculopathy or myopic macular degeneration. So it's a serious problem, and it takes a while for these conditions to develop into serious problems. So the earlier we start, the more people we can save from blindness 30 years from now. And these are a series of slides from Ian Flitcroft, researcher in myopia. And he's been trying to make the point that there are these risks, odds ratios that increase with increasing myopia for these various conditions, maculopathy, retinal detachment, glaucoma, and cataract. But he's made the point that there is a non-zero risk of these conditions for any non-zero level of myopia. So even the first diopter will increase the risk of these problems. Now, the other factor, so it's not surprising that if you have a -15, let's say, that you're really going to be suspicious that when you look inside that eye, there's going to be all kinds of pathology related to stretching, retinal detachments, et cetera. And you're not expecting that in a -3, let's say. But keep in mind that there are many, many more people in the -3 range and below with some elevated risk, and very few people in the -15 range with very high risk. So if you look throughout the whole population, you're actually going to find more of these conditions in lower myopes, even though the risk is lower. So it's important, I think, to do what we can to reduce myopia in everybody. This is another survey. This is a global survey just showing whether optometrists are concerned about myopia, where are they more concerned? They're quite concerned in Asia, which is not surprising. Still, the most commonly prescribed treatment for myopia is a single vision spectacle to correct their distance vision. And that's really shocking and should not be anywhere close to the standard of practice. Some practitioners seem to be concerned about costs, and that there's ways to address that, I think. But these types of lenses and specialty level treatment to actively control myopia would be a specialty service, and there are higher fees for that, of course. You should try to get the International Myopia Institute series of white papers. There's the QR code down there. They are all open access, so everybody can read them, and talks about the genetics, the various types of myopia, the types of treatments, and so it's quite effective and useful resource, even for your patients. And there's some summaries of those that are a little bit easier to get through. And so for all these reasons, the interest level rising, levels of myopia rising, the International Myopia Institute, white papers, all of that. This really is a great time for optometry throughout the world, really, to get serious about myopia. And that's the issue there. Now, for many years, and it's still the case, there are strong and vigorous debates about what's the effect of near work on myopia. And the prominent theory, I think, from academia is that mostly they think it's a lack of outdoor time that's leading to myopia. And I don't know about you folks, but when you're practicing optometrist and when you're a little bit older, like some of us here, you've had a chance to see that there are definitely impacts from reading. So there's a number of studies. There's always studies that go both ways, studies that show that for every increased number of hours of near work, especially closer, that there are increased risks of myopia. There are very old studies that look at what occupational groups had myopia, 100, 200 years ago, and it was always near task kind of occupations. And so I think one factor in finding it hard to come to some agreement about the effect of near work on myopia is we don't measure it very well in large studies. So they're starting to get some devices that can measure the distance and the time and how focused the person is on that task. And but the other factor is I think there are some visual systems that are bothered by near work and other visual systems that aren't triggered into myopia from it. So when you do a large population study and you look at, all right, how many hours have they read? How much nearsightedness is there? It's hard to find much of an association. But if they were to look properly, in my opinion, at kids whose eyes don't handle that very well, and by that I usually mean kids who have esophoria at near, but more specifically, what's been a focus of my early research, something called esofixation disparity at near. So it's always bothered me that when they talk about binocular vision and myopia, they just do a cover test. So they cover an eye, and then they cover the other eye, and then they look at how the eyes move, and they say, okay, that's a measure of their binocular vision. With fixation disparity, you have both eyes open, and you're looking at a disc. You're able to measure precisely are their eyes properly aligned or not properly aligned. And so, especially in the early days, that's how I chose what bifocal ad that I used. Okay. Now, the other factor that's really kind of grabbed my attention recently is that I think that the same kinds of activities that contribute to rise in myopia throughout the world, digital devices, technical work, rigorous academics, those same kinds of behaviors are also likely leading to a massive increase in dry eye. So I think that it would be good for doctors that deal with dry eye, for instance, to start looking at younger kids, and then also for doctors that are treating myopia in younger kids to pay attention to dry eye. And there's a lot of reasons for how digital devices lead to dry eye, incomplete blinking, infrequent blinking. There's a whole rationale for how that leads to inflammation from excess bacterial growth and all of that. So it's worth looking at. And you want to make sure that as you're treating myopia with multifocal contacts, for instance, that you're not contributing to dry eyes. And keep in mind that, like myopia, dry eyes are a progressively worsening, irreversible condition that leads to significant consequences down the road. So it's not insignificant. And this just shows you video capture of an incomplete blink, which is pretty common among computer users. And then, so these are just some behaviors that we see with kids these days. They practically have an iPad or a phone in the womb, I think. There have been some ultrasounds of babies already, on their iPhone inside. No, I'm just kidding about that, of course. Well, you don't have a live audience. It's hard to, but you guys could laugh, the ones that are on there. Anyway, so kids like to multitask, of course, and this is what happens when you take away a digital device, but it's important to monitor how much time they spend on those devices. Now, these are scans from my office from a LipiVue device of two brothers, young. They were in their, 12 to 14, something like that. Practically all of their meibomian glands are gone. Now, what we don't know with these kids, did this happen over time, or maybe were they born with insufficient meibomian glands? And that's not been well researched. And there's some papers down there that discuss dry eyes. And this just shows that a recent paper in adolescents showed that there was a significant level of meibomian gland dropout. So it's worth looking at. And sometimes you can get a decent view of those glands just by transilluminating the lower lid if you don't have this device. Now, these are some of the devices and lenses that might be available in various markets around the world. Various glasses. There's a lot of work on novel spectacle lenses. You might have MyoSmart there, or soon. Essilor's working on something. I'm working with a company that's working on something. There's a company out of Japan that's made some news recently on some spectacle treatments. And then there's the SightGlass lens that's getting close to market, all showing excellent control of myopia. And the key thing with spectacles is you can put them on much younger children. So you get a head start. We might not put a contact lens on a 4-year-old, for instance, but you could certainly put a protective eyeglass on these kids. And of course, MiSight is the one here anyway that has FDA approval. Now this just shows from Earl Smith, the essential theory behind much of the treatments for myopia control, that when you put a regular eyeglass lens on a myopic eye, it fails to bring the focus in to the retina in the periphery. And so you have this hyperopic defocus. And anytime in animal studies, if you studied this in your schooling, but it's commonly known, probably takes another lecture to go through that entirely, but a lot of animal evidence shows that if you either put an image behind the back of the eye or you allow it to be in the back of the eye, you stimulate the growth of the eye and create nearsightedness. So many of the treatments attempt to bring the focus inward. Typically, they target the periphery. So there are a number of theories about why multifocal contacts control myopia. One is that it reduces peripheral hyperopic defocus. Another would be, this is the basis for the argument behind MiSight, is that you just have competing signs of defocus. And actually, when you look at all of the myopia treatments, they all, pretty much all of them have some kind of competing defocus. So essentially you put one focus on the eye for clear vision, and you put another focus in front of the eye somewhere, and that's a signal to stop growing. This is one of my early published studies. We had a pair of identical twins come into the office. We were just about getting ready to start a randomized controlled clinical trial, but these girls came in before we started, but we had the protocol already set, so we randomly assigned them to either single vision contacts, which resulted in the first year in a doubling of her myopia, or a bifocal contact where she had a decrease in myopia. That's cycloplegic refraction. We got an IOL master in the office right about the end of the first year, so we were able to get axial lengths, and they did have, each of them had a decrease in axial length. And pretty much as soon as I got my IOL master, I started to see eyes that appeared to be shrinking. It was very controversial at the time. Most people believe those findings now and are showing them in studies. It's usually a minimal amount, but what seems to be the case is that the choroid is thickening when you expose it to a myopia suppressing stimulus. And with the IOL master particularly, it's measuring sort of the optical axial length. So it's from the front of the front to the back of the back, front of the back, and the choroid's behind that. So when the choroid thickens, it brings the retina toward the front, and so you get a shorter eye. So sometimes it's quite substantial, but mostly it's minimal, but it's I think, a strong signal that the eyes are being suppressed in their growth anytime you see, well, anytime you see slowing really, but particularly if it shrinks. So then we did our randomized clinical trial, used the AccuVue bifocal, which is not currently on the market, although the AccuVue Oasis is a similar design, 2-week lens. And at the time, this was a little bit older population than what they're using these days in clinical trials, but these were all children and adolescents who were already still progressing in myopia. So that was part of the entrance criteria. And we randomly assigned them to single vision AccuVue versus the AccuVue bifocal. We finished this thing in 2006, but it took about 10 years of arguing gently with the company to get them to approve release of the study. So that was quite frustrating. But it was published finally in 2016. That's the paper there and the QR code there. And it was actually received the 2019 American Academy of Optometry Garland Clay Award for the most cited paper in our field. And so that was gratifying, but really quite disappointing. It took 10 years to get it published because it would have been influential in the practice of myopia control many years before and could have helped a lot of kids. So this just shows what we found with refraction over here and axial length over here. You have the bifocal group having a very minimal change in refraction versus single vision. And at 6 months and 12 months, you can see a big separation there, and axial length much less, and in the bifocal, more in the single vision. And this shows all of the results here. So you can see there's a significant number of subjects who had a reduction in myopia, that's cycloplegic refraction, and also a reduction in axial length. Matter of fact, in the older half of the population in the study in bifocal contacts, there was an average reduction in axial length. So 72% was the average reduction in myopia progression in the bifocal contact lens group, and then 80% in axial length. So just a very substantial difference. Now the question can be, because these results exceed any other study that's been done, was the AccuVue bifocal an unusually effective lens? We're not going to know, but 70 to 80% or so is about what I usually get in my practice with modern lenses. So I'm not sure that it was strictly that lens, but remains to be seen if, I think it's hard for clinical trials to show these kind of results because in my clinical protocol written by a clinician, along with my Berkeley colleagues, we allowed for adjusting the prescription to try to achieve what I thought would be the maximum treatment effect with that type of lens. And all these kids had ESO fixation disparity at near, so that's another theory for why perhaps we had better outcomes than modern studies. And this is just a table showing what would have happened if we looked at just the younger kids, because there was some discussion at the IMC or BCLA maybe a year ago or so, speculating that this particular study had better outcomes because it had older kids. And we know that myopia slows with age. So if you do a myopia study on 20-year-olds, you're not going to find a lot of myopia necessarily. So I looked at what my results would have been if we just kept it to modern standards of a myopia control trial, maybe age 8 to 15. And it was exactly the same in terms of the difference, 0.56 diopters of difference in cycloplegic autorefraction if it's the whole population 8 to 18, and even if we kept it to 8 to 15. And then axial length, interestingly enough, exactly the same difference. So for me, I don't quite buy that argument. And I use myopia control on adults if they're progressing. So there's nothing magical about kids, but they're more at risk, obviously. And this just goes into an analysis because a lot of studies suggest that you get most of your treatment effect early and then you don't get any treatment after that, which is just nothing like I've seen in all the years that I've been doing it. So I hadn't analyzed this originally. So we looked at the first 6 months and the second 6 months. So 0.05 refractive increase in myopia in the bifocal group. First 6 months, second 6 months, it's the same. Axial length 0.03 millimeters and 0.03. So I didn't find any difference between the first 6 months and the second 6 months. And then the study only went for 1 year, but I followed most of these patients or subjects or patients now in the practice. And you can see that in year 2 and year 3 and year 4, in the bifocal contact lens wearing kids, and they all were wearing bifocal contacts at that point, or most of them, there was very little continuing change. So if you only get a treatment effect in the first year, you wouldn't expect to continue to see minimal changes as the years go on. And lately I've been looking at a concept of considering what would be the expected axial length for a stable immetrope. It comes from a paper, I might have a citation later for you, from Karla Zadnik, but I used the formula in there to project what would have been the expected axial elongation for a stable immetrope at the same age as all these subjects. So essentially, we take all these subjects at their various ages, calculate what their expected growth should have been if they were just growing children but not nearsighted, and we'd get in that year 1, 0.1 millimeter. And so the kids with bifocal contacts at 0.05 actually had less growth of their eye than what you'd see in a kid who's not nearsighted. And so that's useful to look at because you're not always going to get a complete stoppage of the growth of the eye. It's useful to be able to explain to parents, especially if you're measuring axial length, that if you see a little bit of axial growth, it's useful to give them some perspective on what normal growth is. So I've started to try to look also through my practice at just the years and years of data on various types of lens treatments. I'm still in the middle of this, but I have an analysis here of what kind of treatment effects do we see related to the power of the bifocal ad. So there was just a paper, which I don't have in here, called Blink, where they, and it's worth reading, although it's not open access, so I might be limited to just the abstract. but if you're students, you can probably get it, where they looked at the Biofinity multifocal, which is a lens I've used a lot over the years. Used to be my #1 lens. And they looked at myopia control versus single vision with a +150 and a +250 ad, and they found that the +250 ad was effective and the +150 was not. And so I have here, for instance, in this group of patients who might have been wearing different ad powers at different times during 4 years, so 218 events. And so I just combine all of the progression data for everybody that was wearing a +2 ad, let's say, or less. And we found a 54% reduction in that group, so not bad. And then +2.25 to +250, 77%. And for those kids that were over +250, we found a 90% reduction in their rate. And you can also see in this column that their rates before I treated them went up. So Dr. Liu at UC Berkeley likes to start with a higher ad if you're facing fast progression. And that makes sense. The car is, careening toward the cliff. You want to step on the brakes hard. And at least with my data, it shows that, either that the higher ad is more effective or that fast progressors need a higher ad. Now, this is an expression that I came up with years ago because practically nobody believes that you can control myopia with anything other than a distance center multifocal. And that's just simply not been my experience over the years. And it's probably because I started way before anyone was even talking about it, long before Earl Smith, who you should all know, a good friend of mine. So we joke about this a little bit, but most of his work in monkeys had to do with controlling nearsightedness by adjusting the focus in the periphery. So mostly what he said is that you can control myopia by reducing peripheral hyperopic defocus, and that it's quite effective to do that. And I don't disagree with that, but he's never said that you can't put the plus someplace else. So that's why I say any damn plus, any damn place. And the value of this to you guys might be that if you think you can only use a daily disposable contact in kids, or the market demands it, or you think that you can only use a distance center multifocal and you can't access it there, I would just encourage you to use any multifocal contact lens that you think would be good for the patient, whether it's distance center or near center. This was an old lens, and none of you are old enough to have ever heard of it. Probably it was a Ciba, or Alcon Daily Progressive. And it was a near center lens. It had a massive amount of plus, actually, that they didn't even disclose at the time. They probably said up to 2.25, but I had a friend measure it for me. And it had an ad of plus 4.62. So there's practically no myopia control contact lens that claims any kind of ad like that. But it was in the center. It was over a very small area. And it wasn't very good for presbyopia, but I found that it worked quite well for myopia. So that's the center zone. And it just, here's a lens that does control myopia, and it's a distance center lens. It's kind of like the profile flipped. So if the rationale for controlling myopia relates to competing signs of defocus, you have certainly a competing sign of defocus on both of those. In my analysis of my data, which I presented at this conference 2017, I looked at near center versus distance center, and those are the baseline data, and essentially found the same level of myopia control with this is before, this is all of them together, this is distance center, this is near center, it's the same. So if the best lens for the patient is a daily disposable and you don't have the MiSight, you don't have the NaturalVue, you can certainly try a near center lens and just tell them that I said you could, no matter what all those other people say. Okay, so you have my permission. And this is axial length, also very similar. Now you might have the MiSight, or should be coming your way sometime soon. And so they presented or did a very good study It's gone 5 years now, where they found about 60% slowing of myopia relative to a single vision daily contact lens. And so it's on the market in the US, and it's certainly an excellent lens to try. It's in the old ProClear material. If you've ever used that, it's a quite friendly material, good for dry eyes, I found. So that might be coming to your market. And what they found is about 50 to 60% control. And in this chart, you can see that after the end of the 36 months, they put everybody in the MiSight. You can see that these slopes are quite similar. So whenever you put somebody into a multifocal contact, you can get a clinical effect if they were otherwise progressing. So you can practice myopia control, I think, on anyone that's progressing, and that's just further evidence there out to 5 years. And axial length similar. You can see the difference between the two groups in the single vision and the MiSight, and then when switched, also very similar slopes at that point. And it continues on. Oh, it's hidden by the videos here, so I can't quite see it. And one thing that they did, something I've been doing as well, is at the end of the 3 years, they went out of the randomized trial and put everybody into the MiSight. So the question would be, what would a child have done during those 2 years if they were still in a single vision type of lens? And so they used data to create a virtual control group to show that they were still having a clinical effect beyond what would have been predicted for many studies for kids wearing single vision lenses. And that's, I think, a quite valuable tool. And I'll give you some ways to do that later. It's challenging for them with the FDA. They have to do a number of things after it's on the market. So they should be applauded for taking on this challenging project, but should be going all around the world. I mean, it's been elsewhere much earlier than it was in the US, so you guys might have had some access to it already. And that's just going through some more findings. It's a very safe lens. There was a little bit less success in wearing the MiSight if a child were already wearing a single vision lens, or maybe a little bit more adaptation, because single vision lenses are easier to really like, I suppose. But if you've never had a multifocal in your child and you come in with blurred vision, I think it's a little easier to adapt to it than if you instantly take somebody from a full power single vision lens and then put them in a MiSight or similar lenses and then ask them to pick whichever one is the clearest lens. And you don't really want to give them that power, because the real question is which one's going to keep your eyes safe from all those conditions later in life that kids don't care about, but parents and doctors should. And generally, when they rate these types of lenses, many lenses, multifocals, they're generally rated as equal to single vision lens in quality. The NaturalVue lens, I checked yesterday. It's available closest to you, I think, is Singapore. Not sure if it's in India. China, of course, should have it. I think they do. Anyway, it's a center distance daily disposable lens. I'm a consultant to the company, so I'm doing a study, which some of the results I'll share later. This lens design in chickens was able to stop the growth of the eye because of the multifocal and extended depth of focus design. It was also unique among anti-myopia optical treatments. It was able to reverse the myopia that was induced when they put a -10 on the chicken. You get a -10 chicken, which are the best tasting chickens. But then you put the NaturalVue design on that chicken, the nearsightedness was actually reversed. So it appeared to be a very powerful tool to slow or prevent myopia. And that's been the case in humans, in my experience and the experience of others. This is a study we presented at the BCLA, myself and a number of practices with a total of 141 subjects. You can see the breakdown, about 60-40 female, relatively young population, although we have some older kids as well. 30% Asian. These data are for an average of 18 months post NaturalVue. These are the types of treatments these kids are wearing before. So some of them had none. Many of them were wearing single vision spectacles, single vision contacts. Some of them were wearing other forms of myopia control prior to going into the NaturalVue. This was their rate of progression of myopia the year before, minus 1.07, and then at 6 months, minus 0.05, minus 0.17. So an 84% reduction in myopia progression after switching to the NaturalVue. This is for the entire population. So there's also some myopia control in there. It's a mix of people. So continued slow progression over the total of 4 years that formed this study. And these are axial lengths for a smaller group of patients, mostly my patients, because I had the IOL master. And again, you can see 0.42 millimeters. That's going to be about a diopter and a half, which is close to that minus 1.07, although this is a different group. And then continued slow growth. This is from baseline, so that's why it's higher and higher. So this one here, I can't quite see it. It's hiding, but that's from baseline. So 55% reduction in axial length change at 1 year. Now that's where we start to look at this imetropic axial length growth, because some axial length growth is normal. And so many times in studies, the axial elongation data and the refractive data aren't very close. And part of that could be that some of the axial length growth data is just normal growth. So I like to factor that out. So I do have an app that I created with my son, who owed me some money. So we had him make an app for me. It's called Myopia. It's for Android phones. Usually at my talks, I'll let the attendees have a copy for free. So you can contact me later if you're the one optometrist in Nepal that has an Android and not an iPhone. So usually it doesn't cost me very much because there's very few Android doctors for some reason. But what it does is it allows you to input the age of the patient, their initial refraction, what kind of treatment you're going to look at, and then you can speculate on whether your treatment is, or if their progression rate, if they're a fast progressor, they're showing signs of really galloping out of control, or if they're relatively low risk kind of kids, you can adjust that. And then on the treatment effects for the various treatments, what's provided by the app are average estimates from the literature, but the doctor, it's meant for doctors, can input whatever percentage they think that their treatments are getting. And then it just gives you a set of projection curves over time so that you can see with standard treatment, this kid might end up being, -8, 10 years from now. And then with the various treatments, less and less. So it's useful to show parents particularly, because even when you have a very successful treatment, you see that you expect that they'll get more nearsighted. So you don't want parents to interpret every little increase in axial length or every little quarter diopter of myopia as a failure of your treatment. And you shouldn't promise that you're going to have a straight line, although oftentimes you can get that. But this is the 80% control line. And so even with that, there'll be a little bit of change over time. And then it gives you a table. This type of analysis is available also through the Brian Holden Vision Institute myopia calculator. That's free. And then myopiacare.com, which is a European site, they have this or a version of it available on their website. And that's just a QR code if you either want to purchase that or just contact me, and we'll make it a gift to to the Nepalese optometrists. All right, now I got to thinking just with the tools available inside that app that I could create my own virtual control groups. And so essentially what you do is you use the formulas inside there, which come from a study out of the BHVI on urban Chinese spectacle wearing kids who are myopic and what kind of progression they had over time. So that's the base formula for this calculator. And so what I did in these NaturalVue wearers in that previous study, this was presented at the BCLA, there's a poster on it. I took, so this is the pre-NaturalVue, these are for my patients. So it's carve out of the 141, just my patients. So they were increasing at 1.21 diopters per year. And then after switching to the NaturalVue, they had minus 0.22 over here. So a big change in the year after. Now, what happens invariably with any myopia study over time is the natural rate of myopia is supposed to slow. So if you just look at before and after, whatever your treatment is, you're going to find that the year after should be less progression than the year before. So you could say you should eat more ice cream. And then a year later, you'll find that their myopia rate has slowed, and you might give them diabetes, and you didn't really treat their myopia, but you could show some effect, and that's just the age decay function. So what this does by creating a virtual control group, so I created a virtual control group using the Myopia formula from the BHVI paper, should be a reference later, and I adjusted it so that it would capture the rate of progression we were seeing before. So 1.21, 1.16, that's about as close as I can get. And my kids that come to my practice, a lot of times they come from all around, and they typically have a faster rate of progression because they have parents who are more concerned. So frequently the parents are coming in to see me because they see my research, and so I see more concerned parents rather than just a random kid that's sitting in the chair and I have to explain what myopia is. I have to tell the parent maybe we should do something about it. Many of my parents have kids who are worsening rapidly, so I tend to see a very rapidly progressing population. So 1.16 in the virtual control group, and the prediction is in 1 year, the next year, that they would go down to 0.97. So just under a quarter diopter of difference there, 0.2. And so then that's a fairer comparison. So I think these virtual control groups, they might be able to take the place of some randomized controlled clinical trials, but in any event, for these types of retrospective case series where you have a before and after, it makes for a more legitimate comparison of what truly happened with your treatment, at least based on the population data. And that just shows in another graph pre and post on the NaturalVue, and then pre and post on the virtual control group. So you can see there is a slowing presumed in the virtual control group, but still a big difference between those. Whereas if you didn't have the pre and post, you'd just make this a horizontal line and the difference would look greater. So I think it's a fairer test. Now you can take this formula if you like. I've converted it to be easily placed into an Excel spreadsheet. And what it does is it calculates for you how much axial length you should expect in a normal emmetropic child. And that's the paper that came from. And so if you have, especially if you have axial length, this gives you the ability to better analyze what's the meaning of a 0.1 millimeter increase in 1 year in a 10-year-old. Well, the meaning might be that you've stopped myopic growth. So that's the formula that I use. That's a table, so you can just copy that and you'll know what to expect. You can also maybe take these numbers and use a conversion factor. There's other ways to get to it, but roughly 2.5 diopters per millimeter of myopia. So this would give you well, this would give you myopia, but actually, I guess this is imetropic progression. So it does get a little complicated, the relationship between axial length and myopia. It's not always a simple matter. Now, this is a little project I took on. So you guys probably have shelters in place and lockdowns and kids on remote learning, and everyone's concerned. You'll see a lot of writing on the subject. Mostly speculation and worry from parents and doctors. But what I was struck by is the first 25 patients that I had come in after the lockdown was lifted and we could start to see non-emergency patients again. Of those first 25, I saw practically no myopia. And so that got me thinking, well, we should probably look at this, because I thought maybe these kids were going to lose treatment effect because they're constantly looking close and they're on computers more and they're not outside and there's no organized sports and it's going to be a disaster. And so I now have 64 patients. Now these are all myopia control patients, so we expect them to have some level of control, but you might think maybe the control would be less effective. So in the entire group of 64, this is duration. We averaged about 6 months of between the two treatments, with the COVID lockdown in between. And for us, that was about, well, for schooling is about a 3-month time frame inside there. For organized sports and the like, that's still continuing. So in any case, it's before all the craziness and then after with myopia control treatments. This is the baseline refraction. This is after. So this is a 6-month rate. So we converted it all to be per 6 months, and it was minus 0.04 diopters. And you can see a lot of them with this standard deviation had reductions in myopia, which is not uncommon for me, but minus 0.04 in 6 months is probably better than they were typically getting. And I haven't yet looked at these kids because I should have data from a year ago. So I just started looking at what was last year's, let's say January to June, because oftentimes I see them every 3 months. And I wouldn't be surprised if they actually did better during the lockdown than they did during regular life. And that's going to be interesting to explain. In terms of axial length, also a similar kind of difference. We have 24.91 for the entire group before, 24.99, the 6-month axial elongation rate of 0.08. So that would annualize at 0.16. So that's just going to predict very low levels of myopia in an annualized fashion. We had some kids wearing bifocals, not too many bifocal glasses, including one kid wearing the MyoSmart lens from Hoya. And they actually had a very good outcome, plus 0.17. Some of these were also using atropine, though. And then a little mismatch here between the axial elongation of 0.14 and the refractive data. But refractive data is quite messy. These are not cycloplegic refractions. Now, in the multifocal group, that's the bulk of the kids, 41. They had a refractive change of minus 0.04, so it matches the overall, and an axial length of 0.09, so about the same as the entire group. Ortho-K actually did very well, 18 kids, mostly customized Ortho-K lenses, 0.02 as a rate. We just look at the subtraction there, it's 0.01, but in terms of a rate for the whole group. So practically no axial elongation in these 64 patients, and quite remarkable. So I'm writing a paper on that. It'll be in review of myopia management, which I recommend to all of you to subscribe to. It's free, and hopefully this will be an interesting paper. It certainly goes against expectations. So we don't really know why, and I haven't looked at the so last year, for instance, to see if this is actually better than what these kids were doing a year ago. which would really be interesting. My current theory is that just schooling at home in general is less disciplined than in class. And, the parents have to nag them. Maybe the parents aren't even home. Kids are doing other things. There's not a teacher standing over them. They don't necessarily have 50-minute, time classes where they're forced to do a certain thing. They don't have the peer pressure, let's say, or the teacher nagging them, and parents probably are a little distracted because they're working at home. Maybe they go outside, in school. You only go outside if you're allowed to or told to. At home, you could go outside. You could read outside on your deck or patio, backyard. So I will be sending a survey to these parents for the paper, and we'll see what they think, how they think their lives are different. And but generally, and this is my advice to parents for many, many years, because they ask about reading, they ask about computers, they ask about video games, should they stop their kids from doing all of that? And I generally tell them that if that if they are if they're wearing the proper myopia correction device, which is limiting the effect of near work, then they shouldn't have to alter their behavior. One, it's very difficult to alter behavior. Two, a lot of these kids are in myopic families and academically minded people, at least in my area. And you're not going to be very popular with parents if you tell the parents, well, we just want your kids to be dumb to protect their eyes, so don't read anymore. But this might be evidence that in spite of the really intense reading, which you think would have been a problem, with a proper myopia treatment, it wasn't actually a problem. There was a recent paper I mentioned. Well, this actually, we published this. What I looked at is, because there was some discussion at a recent conference a year ago where they stated that there's no evidence that one treatment is better than another treatment. So you just pick the treatment that suits the child and you just stick with it, because there's no studies that show that you switch from one bifocal to the next, although the Blink study would argue against that now. We know that a higher ad in general is more effective. But I thought that was a nonsensical statement as a practitioner because it's really kind of silly. There's probably no studies to show that if one aspirin doesn't get rid of a headache, that two aspirin might. You just assume that it would, but I doubt if there's any studies that actually prove that. So it's really kind of silly to say that if you're not getting the treatment effect that you think you should as a clinician, that you should just give up. So what I looked at here is a number of patients in that retrospective database to see what happened with their myopia control effect when I changed the treatment. So I have these a number of treatments, 160 cases or so, where we either changed them from a treatment that I thought would be more effective to one that was less effective. Now, normally we wouldn't do that, but maybe there were problems with a higher ad, or we had to change the lens type. And so I characterized that as a presumed reduction in treatment effect. And then we had neutral cases where we're changing from one bifocal to the next, but the ad is about the same, or just two treatments that we think were probably neutral. We changed them not because we were trying to get more effect. And then we have these 55 cases where maybe the myopia control wasn't as good as we liked, and so we increased the ad power, decreased the zone size, or added atropine. And what we found is that for the decreased treatment effect, there was very little change in the myopia control. For the neutral, we had a slight improvement the year after. That could just be an age effect, but we wouldn't expect much difference here. And even in the decreased treatment effect, I wasn't trying to create myopia, so these are not big changes, but they were not in the direction of trying to make it better. But in the group where we tried to increase the treatment effect, we found an increased treatment effect significantly. So that tells me, and 30 years has told me, that if you're not getting the treatment effect you think you should change your strategy. This just illustrates the value of starting your treatments early. So this is a projection of how the eyes would change with standard treatment. This was in publication Eye in 2014. And this just shows what would happen if you waited until they were a -2.5 or so, and maybe the parents start to be concerned, and you do kind of a minimal treatment effect, something relatively ineffective. Well, you're not going to have a big difference there. If you start a little earlier, let's say you start with something moderately effective, it could be a bifocal eyeglass, which is kind of moderately effective, but you start it way back here when they are reducing in their hyperopia, that still gives you a head start. Okay, and then when they start to notice nearsightedness, you bump it up to a 50% expected treatment effect. You can see the big difference there between a -5 and -10. And then this shows, well, let's start myopia treatment earlier in myopia though, but with a treatment effect that's 80%, and that's easily achievable. And then best case here would be doing something as they're reducing in their hyperopia, and then really cranking up the gas as soon as they cross over the line. And that's where you could get the biggest effect there. So start early. And these are some of the resources for you that should be helpful for you. And that's it for today. Accept your questions.
Okay, thank you so much, Dr. Thomas, for your insights. Are you ready to take the questions, Doctor?
Yes.
Our first question goes by Mr. Azaz. He is asking, should myopia be considered as a disease rather than refractive error because of the associated problems like RD, maculopathy, etc.?
So that's being debated. There's a trend toward trying to consider it a disease, but it's not currently considered a disease. I think there's a difference. The distinction I would make is between myopia, for instance, as a refractive condition, and myopia progression as the disease. So if you're a -1 and you stay around a -1, we don't expect big problems for you. But if -1 is your beginning of becoming a -10, then you are facing the consequences of what in essence is a disease. But it's not considered that by insurance companies, but they're starting to think about it. I've been in some discussions with them. I think part of it in the US might be driven by the FDA approval of MiSight for myopia control. So once you have an approved lens, then you have a condition that has an approved treatment that's getting close to being defined as a disease. And I think we should consider it a disease as practitioners and do reasonable things to slow it down so we can reduce the risk of these pathologies in the future.
Okay, thank you so much, doctor. I guess Solu's network is a little bit poor, so I'd like to continue here. So the one question over there after this, what is the expected outcome myopia control by using the multifocal contact lens in dominant or non-dominant eye? In which eye it's more effective?
So, yeah, I don't think there's any difference. I've not seen any difference between rights and left eyes, although I don't have, I could look at, 5 years of data and just assume that most people are right eye dominant. It's probably a fair assumption, and just look and see if I see a difference. I don't think there would be a difference. I did have a very interesting case during the COVID period where a child broke or lost one of her ortho-K lenses. She was a natural -5, I think. She didn't want to tell her parent because maybe there was some, they're out of work and she didn't want to, obligate her parents to spend money. So she's trying to be a good kid. So she just wore one ortho-K lens for about 5 months. So one eye's 20/20, other eye's 2600 with a -5 uncorrected in essence. And what was interesting is the axial length in the ortho-K eye was what we were showing with the Covidopia data, about 0.02 millimeters increase, so about average for that group. But the eye that had no ortho-K, you might think of as an eye that had no treatment, but actually high plus can be a treatment. That eye actually shrank by 0.2 millimeters. So a very significant shrinkage of that eye. So that didn't have anything to do with dominant or non-dominant. It's just how does the eye respond to imposition of plus on one eye? And there have been studies that looked at monovision eyeglasses. That's actually the beginning of the MiSight lens, is a study in New Zealand looking at monovision eyeglasses. So I don't think there's a difference. There is a difference on the biofinity lens, for instance. They call those lenses D and N. People think of that as distance and near, but so there's sort of a connotation there. But originally that was designated dominant and non-dominant. And so you'd go dominant on the dominant eye, which is a distance center, and near center on the non-dominant eye for presbyopes. But that's not how those lenses should be used for myopia control.
Okay, doctor, is it related with the age, or if you have to prescribe on the best of age? So which age group would be a more effective?
You might have to repeat that regarding age.
It will be better, doctor.
I didn't get actually, maybe just repeat the whole question.
Okay, doctor. So what is the minimum age or age group that we can prescribe the multifocal contact lens for the myopia control?
Well, so as I showed in that simulation of, what would happen if you start later or earlier, keep in mind that all you're really doing is changing the slope. So if you want to have an excellent final outcome, you either want a very effective treatment that would stop it, or let's say you're not going to have a very effective treatment, you want to start earlier so you have more time to affect the final outcome. So you would want to start any of these myopia treatments, including contact lenses, at the youngest age that a child is able or willing to wear a contact lens. And you can get some pushback from the child because they're scared. Not all, I don't have a lot of 5-year-olds wearing contacts, frankly, a few 6-year-olds. 7 and 8 is a little easier. A lot of times girls do better than boys. Helps if they're at least marginally motivated. They're all going to be scared. You have to find a way to have the first time that they get contact in their eye a safe and comfortable experience that they have fun with. And then it's easy from there on out. And so keep in mind that there have been studies to look at the question, are contact lenses safe in children? And there's a recent paper, I don't think it's on my list there, but I can find it for you if you need to be able to cite it to parents who are worried about it, or the pediatrician in your area is complaining that, oh, you're going to blind these children or whatever. Especially in a daily disposable soft contact lens, which is the safest form of contact lens wear. When they look at the complications in various ages, the group that does the best with contacts is the youngest group. So, and teenagers do the worst. Now, this wouldn't be surprising to any parents of teenagers, or maybe, well, there's no teenagers listening to this, but they don't listen. They go away to college. They stay up late. They just don't take good care of their eyes. But a 7-year-old still listens to their mother or their doctor. So they actually do very well.
Okay, thank you so much, doctor. And the same, little bit different question here. So how we can master in the multiple contact lens prescription? For example, if a patient has -5 diopter, what will be the power of multifocal contact lens? I would like to listen in the sense of that, how it would be a better for the myopia control.
Well, out of the Blink study, and Jeff Wallin has presented they find that with that lens anyway, the biofinity multifocal in their study, they usually had to over minus it a little bit to get optimum vision. So on a -5 contact, you vertex that down to 4.75, for instance, they might find that you'd need a 5.25 to have optimum vision. Now, that hasn't been my experience. I didn't show it on a slide, but I went back and looked at in my control study and also in my retrospective case series of 200 something patients, what was my average contact lens power in a multifocal various sorts relative to the vertex corrected spherical equivalent correction. So in that case, the 525, it'd be a 475 roughly, was my average prescribed contact a 5.25, or was it, closer to 4.75? And for me, the average was right around the spherical equivalent. Now, I think part of that has to do with, in a clinical trial, you might be obligated, you might be obligated to keep adding minus until no further minus results in some level of improved vision. If that's your protocol, you're going to have a little bit higher minus lens. If, on the other hand, you put the predicted power on and the patient sees adequately, they see 20/20, then I don't usually show them extra minus. Now, it's possible that it doesn't matter, and it's possible that in some patients going overpowered would be less effective. And so when I show that we had 80% control in the randomized study, and I'm finding 80% just in my clinical practice with multifocal contacts, part of that could be that that's my protocol, that I don't over minus. But it's possible that it wouldn't matter, because if the mechanism is that there's these signs of competing defocus, if they're competing and you move it one way or the other, they're still competing. So you're not changing the interval unless you change the add power. So we don't know, but I don't find that I have to over minus. But I'm not too concerned if I have to. You have to make sure they see well enough to be successful with the lens.
Well,
there was a question there about add power. I would probably just start most people with a +250, because that's the highest add power commonly available in disposable, monthly, or easily available lenses. And then you can always increase it if you're using a custom lens. Biofinity also has a custom XR, they call it, for higher add powers. So I would say I would just start with 250 on most people these days.
Okay, doctor. So, doctor, as we very much known about like the correction of the minus correction little bit low. If we consider the -5 in spectacles, we more specifically more focus to prescribing the low power. So can't we say like if we prescribe the low specific low power, it will be nice, or it will be give a more accuracy on the research. So is it anything like that, doctor?
I lost you a little bit there. Are you asking about the distance correction or the power of the add?
Power, doctor.
Distance power?
No, for near, doctor.
Near. So the power of the bifocal.
Yes.
And was the question which add power is the best one to try, or if there's advantages or disadvantages to them for vision?
Yes, we can say it. Yes, doctor.
Okay, so there's some expectation that the higher the add power, the more blur there might be in the distance. And that's possibly true, although I'm not sure that it's actually true. And I think it varies from patient to patient and with different designs. So I have had cases where I've gone to a higher ad power and actually gotten better visual acuity. And I think possibly, and I actually looked at it in those cases, I looked at the shape of the back of the eye with peripheral axial length. And on an eye that was really curved and prolate and stretched, that those types of eyes, at least when I looked at it, actually did well with a high ad power, because you can think that if you have a lot of hyperopic defocus in the periphery and you put a high ad power in, you can bring that closer to actually being focused on the retina. So I wouldn't be shy about using a high ad. You can always increase the distance power if you need to. We expect that the higher the ad power, the more control you have. So if you're not getting the control that you want, then you have really three options. You can increase the ad power. I think you can also decrease the center zone size if you're using a center zone multifocal in a custom contact lens. And I'm sure you have custom contact lens companies there that can make all sorts of bifocal powers for you. So you're either going to increase the ad, decrease the center zone size, which brings the plus closer in, and or do both, and or you add atropine to the treatment.
Okay. So next question is, at what interval the patient using the multifocal contact lens can be called for follow-up?
So recommended follow-up would be the same for any contact lens fitting. So you might want to see them back after a week or two just to make sure they're taking care of them properly. They can put them in and take them out. MiSight actually has an app, if you guys have MiSight, that helps you to communicate with parents and kids and monitor whether they're properly putting them in, if they're having any troubles. But you might like to have some just interaction with the staff and the parent or the child in the first week so that they don't get frustrated. I find that actually they do pretty well. So we don't do that, but it's not a bad thing to do. So you'd see them at 1 or 2 weeks. You might have a power adjustment at that time. It's actually not unusual to find that they'll take a little additional plus at that point. There can actually be very quick reactions of the eye to defocus, such that you get reductions in axial length and decreases in myopia, even in the, well, it can even be 30 minutes, but when you have them back, you might just check with trial lenses, put plus a quarter in front. And usually if they'll take plus a quarter, I'll give it to them. I don't usually show minus power because, you're seeing well. A lot of times they'll take minus, a lot of minus, and it doesn't really benefit them. And so I don't show it to them if they're seeing well. And I do use a lot of toric lenses. Not so much with a NaturalVue, because that does a pretty good job, even in the presence of toricity. But, if you're not getting the visual performance you have before you necessarily think it's because it's a multifocal, you might just hold the cylinder in front of them and get it lined up just right. And if they say, wow, that's clearer, and you have the availability, I would use a toric lens, or if you guys have the synergized lens, which is the hybrid lens, they make now, at least in the US, a distance center multifocal, which doesn't much matter to me because, like I said, any damn plus, any damn place. But on their distance center multifocal, they allow you to change the zone size. They have an add up to a +5. So clearly they did not intend that lens to be a presbyopic lens, although they can't really say that it's for myopia, but it's for myopia. And so if you have that lens, that's an excellent lens when you have astigmatism.
Okay, doctor. So let me check the another question. Okay, so which one is better, PAL or multifocal contact lens? How can we convince parents or patient?
So I interrupted you because you said which one is better. I was going to say 1 or 2, but that's just an optometry joke. I don't know if you guys say which one is better, one or two, but we say that all day long. So which one was better, multifocal contacts or which? Ortho-K?
Yes, multifocal contact lens or PAL, progressive additional lenses.
What kind of lens?
PAL, doctor, PAL, PAL.
Oh, yeah. So progressive addition multifocal eyeglasses are generally thought to be very poor performers in very large studies in the US on a general population of myopes. They weren't selected to be maybe kids who would do better with a bifocal, let's say. They found maybe 18% control. So it's very minimal. When I do use a bifocal, and actually in that split of patients during COVIDopia, I had some bifocal wearers, but several of them were also using atropine, and actually we're doing pretty well. With a bifocal, standard available bifocal, what's been shown pretty well is if you use an executive bifocal, just a gigantic, thick, ugly eyeglass that fills half the lens, which is hard to get most kids to wear, frankly. It's on the market by Essilor, by the way. I forget the name of it. But in a study in Canada on Chinese Canadian kids, they found 50 or 60% control, and probably because it affected a lot of the peripheral retina because there's a lot of plus there. So the implication from that would be if you're in a bifocal eyeglass and you don't want that ugly one, you might go to a flat top 35, which is pretty big and less ugly. If the child is young and they don't have to worry about kids teasing them, or they're just a child who doesn't care about that kind of thing, flat top 35. Been no studies on it, but it's plausible that the best study with a bifocal is a gigantic lens, that larger zones should be better. So I have used flat top 35s. There's a lens I like, may or may not be available to you guys. It's called the Shamir Duo, and it's a mostly invisible bifocal, so not a progressive, with essentially a large rounded segment at the bottom that's blended. So you probably have blended bifocal as a category, and that might be a useful one to try because it's not very visible. And on those COVIDopia kids with the bifocals, 2 or 3 of them had the Shamir Duo in there. And so, but I would say I never use progressives.
Okay, thank you so much, doctor. So there is another question. Do the patients with high myopia have to use the multifocal contact lens for lifetime?
You cut out a little bit there. High myopia.
Yes, doctor, I'm going to repeat it again. So do the patient with high myopia have to use the multifocal contact lens for the lifetime?
Yeah, so that's a little harder to answer. And so I've been using multifocal contacts, like I said, for 30 years. So I do have patients who have been wearing them throughout their lifetime. And some interesting things have happened with them. And some interesting questions have arisen, but I haven't quite written a paper on it. Some people wonder if you keep them in a multifocal throughout their life, would maybe presbyopia come sooner because you're doing the focus for them, let's say in some of these patients anyway. Some patients just ignore the plus, but some patients use the plus, primarily, as I mentioned, kids with ESO, especially ESO fixation disparity near, they actually like the plus. So I'm sure you would prescribe a reading glass for a child with ESO because it eliminates the ESO and makes them more comfortable, avoids double vision, all those kinds of things. So that applies when you're prescribing these lenses as well. So what I do is people wonder how long should they be in these myopia control treatments. I typically take them through the end of college. And by that time they're 21, 22. And most of the studies show, just in general, that myopia doesn't worsen much at that age. There's some patients who continue to worsen, but it's still slower. So they're at less risk. So if I find they go through college and they're just completely stable, especially by axial length, but by refraction as well. That makes me think, hey, they probably don't require this lens anymore, because the two assumptions would be, we found the perfect contact lens, and it's just the perfect treatment, and they still need it. The other theory is, okay, we have the contact that's telling the eye to stop growing, but the eye is not growing. The analogy I use with the parents is, we've been stepping on the brakes for all these years, but currently maybe the car's on level ground and you step off the brake, the car's not going to go anywhere. So I try to make that determination around age 21 or 22. And usually my deciding factor, so long as I'm finding that it's stable, if it's still creeping up a little bit, then that tells me they're still at risk for worsening. I would tend to just leave them on the lens until I see that it's very stable for 2 or 3 years. But so the deciding factor for me would be, if they have a binocular vision condition up close where the plus power helps to make reading more comfortable, essentially that's going to be ESO and ESO fixation disparity at near. If they like the plus, and without it, they would get headaches, they'd get double vision, they'd get fatigue. For any reason, you might prescribe a plus power lens or a bifocal for binocular vision complaints. If they're still in that category, I just keep them in the lens. So these are the patients that I've kept in all the way up to and through presbyopia. And one nice thing about that is that when they hit 40 and 45, they don't really notice it, which is great for their fragile psychology, because they don't have to think about how old they're getting, because they're not getting any of this presbyopia thing, because their contacts automatically are correcting for it. So that's a nice little bonus. The other question people have had is, well, might they get presbyopia earlier because you've been doing all this work for them? It's like where their muscles atrophy. And I have looked at that briefly, although not in a study. But when I've looked at it, these patients that have been wearing these lenses for 20, 25 years or so, they're not entering presbyopia at a younger age. And at age 40 or 42, I'm still finding in the standard ad determination that they're a plus 75. So they don't automatically need a plus 2 at age 40, because we've been giving them a plus 2 for 20 or 30 years. So it's tricky to know when to quit. But the advantage of quitting at age 20 or so, 22, is if they don't need it, they could have 20 years of standard contact lenses, maybe slightly better vision at night, cheaper lenses, certainly 20 years of single vision contacts versus 20 years of multifocal contact lenses. That's going to save them thousands of dollars. So I'm not going to keep them in a lens that's more expensive than a standard lens if it's not going to give them any benefit. So that's how I look at it.
Okay, doctor, I guess we come end of the presentation. Still there is one question. So any study materials that you specifically prefer to enhance the practice of myopia control by using the multifocal contact lenses?
I don't think I caught the first part of that.
Okay. So any study material that you specifically prefer to enhance the practice by using the multifocal contact lenses?
You asked about material?
Yes, study materials or anything that you would like to prefer. If anyone wants to more know about this thing, so where they can go, like study materials, any research, anything.
Oh, okay. How to learn more?
Yeah.
About?
Yes.
Yeah. So actually, there's a conference coming up. I think it's called the Global Myopia Symposium, and it's all virtual now, so you don't have to travel out of Kathmandu, and it's free actually if you don't need continuing education credits. So it's going to be 3 days of high-level myopia education. So I would highly recommend that. And if you need CE credits, I think the fee is like $149, so it's very minimal. But they allow you to sign up without that. And then I'm the editor of a website, manage myopia.org. I kind of stepped away from that this year with the COVID thing, just because it got to be a little bit too much time. But there's materials on there meant for practitioners. So that would be a good source. Myopia profile. So it's on the resource page on the last page of the talk. And so you can go to any of those resources. Let me just look up, see if I got the name right. Global Myopia Symposium 2020. Yeah, I don't know if is that still being shared?
No, doctor. Actually, I guess it's a PowerPoint only shared. So
Oh,
I
I
guess
see.
you have to share your screen. Yeah.
So anyway, it's Global Myopia Symposium. Just search for that. And I think it's a 3-day conference. So that would be a great one to start with. And then, all these various Myopic profile, Kate Gifford, they do a lot of writing, Facebook on Myopia profile. And there's some resources there for assessing risk. Also myopiacare.com, which I participate in. It's a European site, but they have a risk profile for parents to fill out, a doctor locator, so you can get listed on there for people who need, who search for it and they say, well, where can I go in Nepal, let's say, to help my kids? And so you can get listed on there. There's no charge for that. So those are all the resources there that I think would be useful. Of course, Brian Holden Vision Institute, globalmyopiacenter.org is on there. That would be useful as well.
Okay, thank you so much, doctor. Let me check if there is any question.
I could recommend, if they're not in Nepal yet, they might still allow it to become certified with MiSight. So the certification process is currently free, and probably take you 2 or 3 days to go through all of the learnings on that site, but you can become certified. And actually the BCLA, which I'm quite sure you're familiar with, has some presence there. They have a myopia management certificate, so you can take courses and become certified in that. So those would all be great resources for you.
Okay, doctor, we'd love to go through this website, and I definitely want this link from you on Messenger, and I'll be dropped to all the audience here. So I guess we are end of the session. So let me check if there is any question. All right. Okay. Okay, I guess we have answered most all of the question till now. And considering the time here, I announce the closure of the discussion session. And I would again like to express my immense gratitude towards Dr. Eller and to all the attendees for their endurance. Also, I would like to thank all the direct and indirect helping hands for the Today iTalks program. Before wrap up, I request our today presenter, Dr. Eller, to share a few words towards our program.
Oh, what was that? You still have work for me to do? What was the question?
Okay, doctor. So do you want to share anything about our program or any good notes before ending the session?
Well, I think it's great that a young profession is taking an interest in what's destined to be a very important part of optometry in a way that in any country, really, no matter the level of training or the age of the profession in that country, you can start to really help kids. And by doing so, you can reduce the future burden of visual impairment. So it's really important. and we have all these tools available, and it's just something that parents appreciate, and it can it just really be helpful to society. And you may not see the benefits within your practice lifetime because in terms of pathology, it's going to be hard to know really, but once myopia control is commonly done, I'm quite confident that there will be much less blindness in the world. And so what could be better than that?
Thank you so much, Doctor. It's our immense pleasure to have with you us today. Herewith, I announce the close of today's webinar, hoping to see you all again tomorrow. Stay safe, stay connected. Thank you so much.
Thank you.
You so much, Doctor.
Okay. That was fun. And one day I'll get over to Nepal and see what it is I'm missing there behind.